Services Committee to order, and Senator Orrock, you're on line 2. If you'd open us up in prayer. Thank you.
Thank you. Let us bow our heads. Heavenly Spirit, we call on Thee for guidance. We call on Thee for resilience, for courage and wisdom to carry out our business here, tasked with serving the people of this state and standing up for the principles that have been shared in the holy books that our many denominations and religions have before them. We thank you for this day, for the ability to serve, and pray that thy wisdom guides us in our deliberations. Bless us all. Amen.
Thank you. Just a little homework here. We have one bill today, and then we have a presentation. We'll have our meeting times are going to be Monday. It's going to be the short time, so is going to be 2 to 3, and then our potentially longer will be 4 o'clock till we're finished. As you know, we haven't been keeping people longer, but that is the allotted time if we need to go longer from that perspective. Monday 2 to 3, Monday 2 to 3, and on Wednesdays at 4. So there's no meeting afterwards. That's why I'm saying in this room from a conflict standpoint. You look like you have a question. All right. The Vice Chair has a question.
Mr. Chairman, since we have the Chair of Public Safety in here, do you think that we could work something out so that they could get out of our room on time?
We'll see if he wants to have his bill heard or not. Okay. All righty. So thank you. We much appreciate that. I mean, I think that we're all trying to work together and trying not to have conflicts and so forth. That's just not an unusual scenario, is it? All right, so that's a little homework there, and so we have one bill, SB 58, and that's in your folder, LC 394531. Chairman Albers, you are welcome to come here or the podium, whatever you would feel more comfortable. All right, so the mic is on and the floor is yours.
Mr. Chairman,
you got the Colonel here. Thank you for being here. Colonel Hitchens is he's head honcho, but he is really more known for being from Effingham County in my area, not my district, but my area. Thank you for being here.
Thank you, Mr. Chairman. Hopefully that will bring me good favor because the Colonel helped me to create this bill. In addition to his role as Colonel of State Patrol, he is the Commissioner of Public Safety who governs a good portion of those who would run what we call emergency in this state. This is Senate Bill 58, which is the Georgia Transporting Life-Saving Organs and Personnel Act. As most of you know, this is very personal to me. Several years ago, about 3.5, I donated a kidney to my son, Will, and I really found at that time that was God's calling for me. It could have happened to anybody. It happened to us. And from that, I believe everybody was here who was kind enough to vote for and support the Giving the Gift of Life Act, which became the law not just in Georgia, but it is in most states now. And I work with a lot of national organizations, from the Kidney Foundation, the American Kidney Fund, the Liver Association, the Georgia Transplant Foundation right here, LifeLink of Georgia, some of the names that I know many of you know. What we found out was you've probably seen one or two of these throughout your time. You may see what looks like either an SUV or other type of a vehicle that has organ transplant on the side of it. And those vehicles are designed when there is a time-sensitive need to get a life-saving organ. Now, it could be for a living donor like myself. Anybody here? God gave you 2 kidneys. You only need 1, thank God. And for your liver, it is the only organ in your body that actually regenerates, where you can give a portion of your liver away. But we also know folks at the time of an untimely death or timely death that they have hopefully signed the back of their driver's license. They became organ donors. And we've really seen a great increase in that. And in Piedmont Hospital, we have one of the most state-of-the-art organ recovery centers in the nation. What happens, though, is there is a fixed time from them taking that organ from one person and giving to another. My scenario was ideal. I was so fortunate to be at Emory Hospital, and I was at OR1, and my son Will was in OR2. But that is not always the case, and it's almost always not the case when you do something called a paired exchange, where I might be giving a kidney or part of my liver to one person because I'm not a match, but their person is a match. So it goes back and forth, or an untimely death. Sometimes we just need to send that organ. You will see it happen sometimes in airplanes and in vehicles, and a kidney comes in something called a cycler machine. It looks like a little igloo cooler, and that keeps that going for a certain amount of time, but they expire, and that organ eventually will become unavailable to be transplanted. Also, in certain instances, you need the whole medical team with him, like for a heart as an example. And we need to make sure if there's a timely need to get that organ and those people from point A to point B, that they can run emergency. What you see in this bill, and I won't take you through each and every section, thanks to the Commissioner and Colonel, we just reflected the process to be very similar to the way we do ambulances today. Now, they have to have the right amount of lights and sirens to make sure they're all covered properly. The folks who are driving these vehicles have to be certified to drive these vehicles. And interesting point, almost all of them are retired law enforcement, fire, and EMS who do this. This is their way of giving back and having some secondary income in their later years. The process was made, and I'm going to ask the Colonel to say a few words after me if you'd allow it, Mr. Chairman, was so the process would be followed through, would be thorough and streamlined to make sure this is done. Now, I can tell you there's not a whole lot of vehicles that do this and a whole lot of people in the state to do this. I hope this increases, and they're not going to need to run red lights and sirens that often. But when they do, it'll be no difference that we do when one of our police officers is responding to emergency call, a fire truck is going to a fire or other emergency situation, or an ambulance is going to get someone who needs life-saving care either to the scene or then to the hospital. So with that, again, I won't read each and every section to you. It's actually pretty straightforward the way the permitting process will work and working with our folks both on the health side as well as public safety. And with that, I would yield for some questions and again offer if you'll allow the Colonel to come up and speak for a moment.
Sure. Do we have any questions from the committee? Seeing none, why don't you,
Please.
Colonel Hitchens.
Thank you, Mr. Chairman. And as Chairman Albert said, we worked on this bill together and got our permitting section involved. And some of the things that we want to make sure that we took care of was making sure that there was a vetting process, that just anybody that slapped a sticker on the side of the car and said they were organ transplant was not able to get the red lights and just use it as they see fit. So there is a way that they go through and get vetted, make sure that the people are who they say they are and they have a reason to do it. And as the chairman said, this is not something that you would see happening every day. It'd be those that are timely, where the organ may need to be from point A to point B in a certain time, or a surgeon who is the only person that could do that, and it would have the opportunity to turn their red lights on and move through traffic as anybody in an emergency would. They would still be under the same rules and regulations of any firefighter, ambulance driver, police officer, of having to use due regard as they travel about, even with emergency lights on. And one of the things that we did discuss, and we all deal with it every day, with the traffic in Atlanta, you never know when the interstates get shut down, and that allows them to be able to at least get up to where law enforcement is or somebody and let them know what's going on, and then pass through and be able to get the organ in the proper place at the proper time before it expired. And I'd be glad to take any questions if anybody has any.
Do we have any questions from the committee? Okay. That sounds great. So there doesn't seem to be any questions. Senator Allwright?
Thanks so much for being with us and being a critical part of putting this bill together. You doubtless, I'm sure, remember when we had an incentive for people to be organ transplant.
Yes, ma'am.
And indicate that on their license, and we gave a $5 off on the cost of the license. You recall that?
I certainly do.
We're of that generation.
Yes, ma'am. Unfortunately, I am.
And it might be, to the author's attention, worthy of consideration going further. It was one of those things that got cut, when the economy went down, and they're looking to cut everything. But it's a very worthwhile incentive, and there's always a shortage of these organs that are lifesavers. So just for the committee and the authors' consideration, I thought you might have had your arms around that. Thank
Yes,
you.
ma'am. Thank you.
Was there higher donation rates or people who signed the back of their card? Do we know that answer?
I do not know that.
That's a good question.
I was very young when I took part in that.
Yeah. All right.
Very young. Yeah, I was too. Our health committee chair in the House is the one that instituted it.
You got a double renewal.
Oh,
I got a 10-year renewal.
you got a renewal incentive too. It's very worthwhile considering, and it's a measurable thing, to see if it's successful going forward. That's not the bill before us, but it brings it to mind.
Appreciate the thoughts. Any other questions at all? Anything you need to close out? Anything else you need to say?
I'll be very brief because I don't want to slow you down. I would just say that this bill will undoubtedly at one point save somebody's life, hopefully many lives. And Senator O'Rourke, just to address your question, Senator Halpern actually made the motion, and we just passed a bill to create 2 license plates in Georgia, one for the Shepherd Center and the other for organ donation. And those proceeds will go to the Georgia Transplant Foundation, which will increase organ donation, help those families during that critical time. Thank you,
great.
Mr. Chairman.
Thank you, Mr. Chairman, and Senator Kirkpatrick.
If this is the appropriate time,
It
I'm ready
is.
to offer a motion to pass for LC 394531.
Second by Senator O'Rourke. And any further discussion? If not, all those in favor say aye.
Aye.
All those opposed, like sign. Passes unanimously. Thank you.
Thank you so much.
Thank you, Mr. Chairman. That's a good bill. We appreciate that. We do have left Dr. Sunil Tragata, tardive dyskinesia awareness presentation. This is for information only, and if you wouldn't mind taking the podium there, and we got a handout in the thing. So tell us what tardive dyskinesia is and what to do about it.
Absolutely. Thank you, Chairman and members of the committee. Thank you for giving the opportunity for us to present this. I try to keep the medical jargon out as much as possible, try to get the nuts and bolts in a few minutes and see what this is and see what we have as challenges in front of us. My name is Sunil Katragada. I'm a psychiatrist, been here for 16 years. I'm a medical director at Peachwood Hospital. I also worked in a mental health center for a number of years, ran Avita Community Partners in the North Georgia for years. So I have experience in the private and the community setting. So I think it definitely transcends every setting, so it's everybody's problem. So I think it's good to have awareness for providers and also for the community and patients. So let's get to it. Tardive dyskinesia is a word, I know it's kind of tongue twister. Tardive means it's a delayed. That means it's a slow onset. And dyskinesia means kinesia is a movement, dys is abnormal. So it's an abnormal movement that starts slowly or at a delayed onset. So it's a movement disorder. It's a kind of a disorder like you might have seen patients have a Tourette's or Huntington's disease where you have a twisted mouth and blinking and jumping muscles, and you can see a lot of abnormal movements, a kind of a strange moving person around. And those are all the neurological disorders. The difference is that tardive dyskinesia is a drug-induced. So it happens because we use certain type of medications to treat mental health conditions. They're called antipsychotic medications. You might have heard some names like Seroquel, Risperidol, and all those antipsychotics. And also you heard older ones like haloperidol, perfenazine, Perplexin, all those things, right? So older and newer. So we've been using antipsychotic medications originally to treat schizophrenia, like a psychotic disorders. Over the time, we started using them to treat bipolar disorder, depression. Now they are very commonly used for a number of conditions. And we use antipsychotic medications to particularly target certain chemical called dopamine and bring it down a little bit because excess would cause hallucinations, delusions, mania, and all that. So our goal is to kind of bring it down a little bit. And they do beautifully, and they help. But our brain is smarter than us, right? So we try to find it, they find a detour. So when we try to fix one thing, and then your brain will go around and try to overcompensate and to change it. They try to bring it up. When we try to bring it down, we bring it up. So unfortunately, in our brain, a lot of areas have different functions, not just the mental health functions, right? So the dopamine is a chemical, just like a serotonin. It controls not just the mood, learning, and memory. It also controls the movements. It's not our intended purpose when we use antipsychotics to treat these conditions, but it happens anyway. So in the olden days, when we were using Haldol and all those things, Thorazine to treat schizophrenia in 50s and 60s, when somebody has abnormal movements, first thing that comes to a provider's mouth is, oops. You get stuck. You get the feeling being stuck between rock and hard place because you can't take them off. You can't take them off because they're going to get psychotic or they're going to get manic. You know how it happens. So you get depressed or they get suicidal, they get homicidal, they're all dysfunctional. So you don't have a choice. You can't bring it down, you can't go up. Either way, it gets worse. You're stuck. And you can't take them off because they're going to get sick. You can't continue because this condition continues getting worse because it becomes irreversible as it gets severe and severe. And we didn't have treatments for this condition until 6 years ago. So we were using a lot of vitamins and all that stuff, supplements, but they were not effective. So only in 2017, we had 2 medications that were approved for this condition. But a lot of treatment systems, algorithms, and practice guidelines kind of incorporated the new paradigm shift in finding these 2 medications to treat this condition, because the time is in a sense in treating this condition because you had to catch it when it's mild. When it gets a moderate to severe, it becomes irreversible and it doesn't respond as good as it usually does at the early stages. So that's why I think it's critical to catch it early and treat it early. That way it doesn't have a huge impact because it's not something that we can ignore either because it has huge impact on physiological function, physical function, social and emotional because they keep them out of all the public domain, right? They can't travel in the public transportation. They can't go to work. Sometimes it gets to the point where they can't even hold the fork and they can't stand up. So they get totally disabled if you leave it alone and don't treat it at all. So that's why there is no question you have to treat it. But the question is, are we treating it? We are not. So right now we are estimating 600,000 to 1 million people who suffer from this disease entire United States. But we are treating only 10% or less of all that. Can you imagine if you are a family member who have a high blood pressure or diabetes where you treat only 10% and 90% go untreated? No, we don't even do that for schizophrenia or bipolar. We treat a lot of them. So unfortunately, that's the fact. So that is happening because of a lack of awareness among patients and also among providers. Providers knew it for a long time that it happens with antipsychotic usage. But we learned to have that learned helplessness for a long time. So we just on and pause and then move on. Okay, this is something you have to accept it and move on because you have to take this medicine. I can't do anything. Honestly, there was not much they could do for 60 years until 2017. But now there are 2 drugs that are very effective. They treat 90% of the symptoms. If within a year, 97% of the people had some response to these 2 drugs. But we're not catching up with changing our policies and algorithms. That's where I think I want to focus on, because we have a Department of Community Health policy manual that gets updated monthly. And if you look at the recent version, I was just browsing through before I came in, and then manual says that if you prescribe antipsychotic medications, you need to monitor whether they develop tardive dyskinesia. In short, they call TD. So whether TD happens or not. Or you have an exam called AIMS, that's called Abnormal Involuntary Movement exam. You have to check and measure how severe it is. So you have to do that during appointments and then document it. And the policy manual stops right there. It doesn't tell what to do next. So unlike a lot of other guidelines are catching up. For example, American Psychiatric Association caught up in the new practice guidelines. It say if somebody has a moderate symptoms of TD, standard of care is now to prescribe one of those two medications. So that it became like a minimum standard. Even though it's a minimum standard, it didn't really get into all the algorithms and policy manuals. You know, we are always behind in the community health side, right? We are the last ones to catch up. So we have to catch up because this is a disease that doesn't stop. It keeps going and gets worse and worse, and it has at some point more impact than actual schizophrenia or bipolar itself, even more disabling. And when it gets severe, it can't really change anything. So that is something that I want the committee to be aware of it. So maybe give input to the DCH manual updates, and hopefully we incorporate steps. We shouldn't stop when we diagnose TD, and we should get to the next step, the recommended treatments. These are standard of care. All the treatment algorithms include that, adding those medications for treatment. So you can fundamentally change quality of life these patients when they have a TD. Because if you see some of the videos, unfortunately I don't have anything to show presentations for because it's a limited time, but if you look at it online, if you Google, you can go to the website. I would suggest mind-td.com. There are a lot of videos to show the mild, moderate, and severe symptoms of TD, how impairing it is for a person. The tricky part is awareness is needed not only for providers, also for patients, because patients are not self-aware. A lot of times my patients, when they come to me, usually they don't even believe that they have it. So other times they come say, oh, my wife is saying that I was sticking my tongue out. Did I? I don't do that. So that's how we start the conversation. They're not aware until it gets to the point where they can't hold the fork, or they can't move, or they can't stand up. Yeah, that is a problem. But in the early stages, usually the family members or spouses or other family members, they're the ones who catch it. So the lack of awareness with the patients, families, and also the community, and then our policies and providers, all of that has to change with new knowledge and new options we have. Having said that, I think I will stop right there, and then I'm happy to answer any questions.
Yeah, anybody with questions on the committee?
Thanks for your presentation and being with us today. I am familiar with this, and I've seen it in people that are chronically unhoused and just come by your house, and they just looking for help everywhere, and the
Yes.
TD becomes more and more pronounced. So I have
Yes.
personally seen it. That gentleman is no longer with us, but he was a chronically homeless person who had schizophrenia, and was treated with exactly what you described.
Yeah, that's a real problem, because
right.
Especially with our community mental health, it's even more important because we tend to use a lot of older generation medications. One of the reasons is the cost,
That's
and
right.
also the strength of medications. The older ones are still golden because they work much better than newer ones. So we oftentimes go back to the old ones or combine old with the new ones. If you prescribe the old ones, you have 1 in 3 patients develop TD. That's a lot.
That's a lot.
The newer antipsychotics, it's actually 1 in 15, which is still 7%. That's a lot. If you're treating hundreds of patients, there's a
Sure.
lot of people develop.
Well, my question is what needs to be changed in order to catch up is the fact that it's not, the remedies are not included in the manual that
Right,
our Department
right,
of Community Health
right.
operates on.
Right.
Then that means, does that follow from there that insurance doesn't cover it?
Insurance does cover it.
It does cover it.
Because
So what's
it's a
the
standard
impact
of
of that?
care.
What's the impact of the community health agency
So
not
you-
having it in the manual?
Right. So not having means you're not necessarily taking to the next step as a requirement. So once it's in the manual, once it's standardized, and then it's all providers and everybody has to follow, right? Then you have to think, you're forced to think about next step. Right now, they are doing it, they're doing Ames exam and then diagnosing it. It's very easy to diagnose. It's not that hard, and easy to measure how severe it is. And then we're documenting very nice, but we're not taking to the next step. There are 2 medicines out there. We're not discussing with patients, we're not prescribing them, and we're not doing the homework later. So we're stopping right there. So that's not a requirement so that we can get away with not doing next step. So you are really a good provider. You're going to take a next step, whether it's in the manual or not. I know you might wonder why you can't do it if it is a standard of care, but you know how it works. We always go with, what is required, minimum required in a community mental health side, then, what you can do the maximum to the
All right,
patient.
Chair Lady Kirkpatrick.
Yeah, my question, thank you for your presentation, is about the timeline when someone starts on antipsychotics or some of the other medications that cause problems. How long after that? Is it 10 years, 15 years? Is there some length
No,
of
we're talking
time?
about months. So the DSM, which is our manual, say you have to be exposed for 3 months. So you can develop any time after 3 months. So vast majority develop around a year, 2 years. It depends on a lot of other factors too. If you are a female, you are more at risk. You're postmenopausal, more at risk. You have a mood disorder, more at risk. Older antipsychotics, more at risk. Based on just like a cancer, you have multiple risk factors. You have more risk factors you develop faster. Younger the patient, you develop faster. So there are a lot of reasons. Some people develop faster, some people don't get it at all. So it can happen in as early as in a month if it's a geriatric patient. Over 65, they can develop TD within a month even. Thank you.
Thank you.
That's a good question.
Any other questions? One,
Yes.
Senator Harrell.
Yes, ma'am.
So what is the process for updating the DCH manual, and is there anything that we as committee members can do to help?
I'm sure there is a team with the policy manual updates. Commissioner Tanner and the team going to have to look at and incorporate into following American Psychiatric Association practice guidelines. Take it directly from there. Practice guidelines are there to follow because they include all the evidence and they don't just recommend practice guidelines. They're there for a reason. I think we had to bring it into our practice manual, our policy manual, and apply to all our community health patients.
So, Mr. Chairman, would it help if there were letters from committee members to the
They would,
heads
I
of
mean,
the
there-
agencies?
Chairman Tanner, as you know, he'll be presenting for health appropriations. He's done that in the House. He'll do it here in the Senate.
Yeah,
Budget
Yeah,
yeah.
in the budgeting process.
Yeah, I'm sure there are other factors because there are very pricey medications. They're brand new medications. They've been there on market only for 6 years. There are no generics available. That means it's going to definitely cost a lot compared to typical other psychiatric medications. So have to take all that into account. But there are no other alternatives.
But you're talking about community health, not not Tanner's agency.
Well, it's Tanner that does I think would do the update on that, but it is, a monetary issue, so it does do DCH too. So,
Yeah, community
okay.
health.
Any other questions at all?
Thank you.
I just want to put one more.
Yes.
And you may not have knowledge of this. In other states, are the states all over the map in who's got it in their manual and who
They're
doesn't?
all over the map, even in a private settings like private hospitals, private clinics. They're not even fully there yet. The reason is the same, awareness, even same providers treat in the community mental health and private, so they behave the same way, right? So unlike community mental health, they have more options, and private insurance is more funding available or can afford more. So they do have more options. So it's more adopted in a private settings compared to community mental health settings. And if you look at patients in a state psychiatric hospitals, these are the ones who have not 3% or not 30%. You're going to see probably 60, 70% of them that have TD if you walk through the psychiatric hospitals. But none of them are on any of these medications that are available for 6 years.
Wow. And the later the treatment starts, the results are less
Right.
effective.
They're not as effective. So it may control 50% of the symptoms or 40%. Your dividend gets smaller and smaller as you pick up late.
All right. Thank you. Appreciate your
Thank you
insight.
so much
and
for the opportunity.
Appreciate it. Meeting adjourned.